In this course, you're going to learn how to do a lumbar and cervical spine screen in patients with neck, back, arm, and leg pain, regardless of the chronicity of their problem, previous diagnoses, or imaging findings. If you're a primary care provider and you're not using these two simple screens for patients in clinic, then you're potentially wasting a significant amount of time on your MSK patient population, causing unnecessary clinical and administrative burden. The training is broken up into 4 separate videos. This video is going over why these two screening tools are so important to use in clinic. The second video dives into the evidence behind these screens, and video number 3 and 4 will show you exactly the mechanics of how to use these screens in clinic immediately. So the biggest reason for using these screening tools is because they can save you a significant amount of time in clinic by reducing repeat visits. For example, instead of taking 10 visits with somebody with low back pain, you can see them in 1 or 2 visits. And these screens can identify many people with rapidly reversible painful lesions. This is a literature validated phenomenon based on a relatively recent medical discovery. In the literature, it's also known as a derangement, directional preference, or green flag conditions. Because this is a relatively recent medical discovery, physiotherapy and medical schools are not teaching it, and you'll get patients that you refer to physiotherapy that will end up back in your office having failed exercise-based care because the PT wasn't looking for a rapidly reversible lesion. And that's quite remarkable because these are simple, self-directed spine movement screens that you can easily guide people through over video or phone consultations. And it's actually a lot of fun for both the patient and the primary care provider, which doesn't happen very often in medicine. For example, here's a case study of a family physician, Dr. Kreutzer, that had a patient limp into his clinic with debilitating acute sciatica. And the patient walked out after that visit pain-free. All he had the patient do was 30 repetitions of a lumbar spine screen, and his symptoms rapidly centralized and reversed without needing any medications. But this isn't just for acute issues. There's many people with chronic pain that have underlying rapidly reversible lesions that have been misdiagnosed and sent down the wrong care pathway. So this was one of my patients, Mo. He had 40 years of right side neck and shoulder pain. He was labeled as a rotator cuff tear, confirmed by ultrasound and 2 separate MRIs, and was treated as a rotator cuff tear for decades with standard physiotherapy exercises and medications with no improvement. He had 3 separate joint injections with no effect. He was referred for rotator cuff surgery, but they had to call it off as he was laying on the operating room table because he was at too high of a risk for the anesthesia. I saw him about 4 years after the surgery was called off, and we used this cervical spine screen and rapidly reversed both his neck and shoulder pain by 95% within 72 hours. So Mo's pain was referred from the spine that presented like a rotator cuff tear, but it wasn't. And on top of that, it was a rapidly reversible problem with 1 simple exercise. So 40 years of suffering from pain because this cervical spine screen was not done on the front end of his care. And these stories are not uncommon. Once you start using these screening tools in clinic, you'll see these rapidly reversible lesions quite frequently. Recent data shows that up to 80% of spine pain is rapidly reversible with 1 to 2 simple movements. And then roughly 60 to 70% of those can dramatically improve with some variation of extension of the lumbar spine or the cervical spine, which is what you'll be learning with these screening tools. In addition, about 43% of isolated arm and leg pain is rapidly reversible extremity pain of spinal source, or XBOS as it's known in the literature, and a large percentage of these individuals can be treated with simple lumbar and cervical extension exercises. These XBOS conditions are problems that are masquerading as rotator cuff tears, like in the case of Mo, but they can also mimic tennis elbow, hip bursitis, knee arthritis, jumper's knee, Achilles tendinopathy, and plantar fasciitis, just to name a few. So if patients don't get these screens, they have a very high probability of being sent down the wrong care pathway. And many people, unfortunately, end up getting operations on the wrong body parts because of this, which was almost the case with Mo. So it's absolutely crucial that these screens are done at the primary care level and are done properly. And if you're interested, you can go to the Disruption MSK website, www.disruptionmsk.com, to see many more of these cases where there were rapidly reversible painful conditions that were easily picked up using these cervical and lumbar spine screening tools. And then in the next video, I'll dive more into the evidence behind these screening tools, and then we'll go into the videos of the actual screening tools themselves.